Hello, my friends. I have a couple new faces in the audience, so that's kind of intimidating, but it's okay. All right, so I'm going to start my presentation. I know Sean kind of told you guys a little bit about what we're going to talk about, but this hits home for me, and I'll tell you why. So I think a lot of us in the audience are very avid exercisers, and if you're not, then this may encourage you to do so. But for those who do exercise right now, I want you to think about why you wake up on a daily basis and go to the gym while we're going through this presentation. So I know Sean gave you a little bit of a introduction for me, but I couldn't do this presentation without talking about my cat for a second. So I did go to Ohio State. I graduated in 2018 with a degree in health promotion, nutrition, and exercise science. And everyone in my class was just so driven to do like a physical therapy route. And I'm sitting here like the first year, and I'm like, why does everyone want to go into physical therapy? Like, look at what exercise and nutrition are doing inside our body. What are our organs doing with nutrition and exercise? Like, it is great what it does for our muscles and our musculoskeletal system, but it goes way deeper than that. And so really early in my undergraduate career, I said, you know what? I'm gonna go on and pursue a degree in medicine. And I graduated, and I started just like a traditional medicine PCA job at Riverside in the emergency room. And I was on Instagram one day, and I get this ad for this tiny clinic called Grandview Primary Care. And I'm like, I'm gonna look into this. So I start looking into it, and it's like, we want a person that's passionate about exercise and nutrition, but also has a medical background. And I'm like, I'm confused. I'm like, this is weird. Like, this is my calling. So I show up to my interview, and there's two people in the office. One is Rebecca, and one is Sean. And I walk in, and we go in this little room, and there's a gym over here. I'm like, yes, I love this. There's a DEXA. And I start talking to this guy, and I'm like, his dream is my dream. Like, how did I find a doctor that wants to do exactly what I want to do? Like, this is incredible. So I end up getting the job, and I think everyone knew I was going to go on to become something in the medical field. And I became really passionate about becoming a physician assistant because of the collaboration aspect of it. But also, I knew that I was going to be supported by a physician, and he's going to learn a lot from me because of my undergraduate degree, right? Because in medicine, in medical school, you don't learn about exercise. You don't learn about nutrition. I had one class on lifestyle medicine, and I'm sure Dr. Jacko and Dr. Bailey could say the same thing. So that's why I went into medicine. I wanted to change medicine, and that is what today's presentation is about. So as you can see, we got some pictures up here. This is me, 2016, after Curtis Samuel ran that touchdown and laying on the football field. Super excited, overtime, right? And then I may or may not have a cat named after a football player. Braxton Miller. All right, so let's kind of talk about chronic disease here. So I'm going to hit on a couple topics, and it's going to kind of flow together, and you'll see why. So chronic disease are diseases that develop over the lifespan. The first one we're going to talk about today is osteoarthritis. We'll talk about hypertension, coronary artery disease, and atherosclerosis, type 2 diabetes, and Alzheimer's. Okay, so you can see up here that a lot of America, or in the world in general, is affected by chronic disease. And a majority, I would say 70 to 80% of it is lifestyle driven. And that's why this type of medicine is so important for our patients to know. Okay, so let's dig into arthritis here. So this is our normal joint, right? It's beautiful, there's no inflammation, you got a nice joint space. And then as we get older, all of that exercise and activity catches up to us, okay? So arthritis is a degeneration of the joint over time. It's an actual loss of joint space. And it tends to, what happens in severe arthritis, it's bone on bone. And so it makes it really, really difficult for you to move properly. When you're bone on bone, inflammation occurs. Okay, so if you look at this x-ray of the knee, this is an arthritic knee, and this is a normal knee, right? So we have a nice, good joint space here. There's nothing here. This is severe arthritis. This needs a joint replacement. So basically, what causes arthritis? It starts now. It actually starts young, when you're in, I don't know, Little League sports. And you, let's, for example, say you slide into first base and you jam your shoulder. That injury is predisposing you to shoulder arthritis. And let's say, like me, I was a gymnast and a cheerleader. I would run and do flips on basketball courts like this, and my wrists were always hurting me. I'm predisposing myself to arthritis in my wrists. Runners, holy cow, runners. We all love to run, I get it, but man, running on a hard surface is really, really hard on the hips and the knees. So, how can exercise prevent arthritis, right? So, exercise 100% causes arthritis, unfortunately. But how can we make sure this doesn't happen to all of us? So, number one, it helps with weight control. That's a no-brainer, right? So people who exercise tend to have a lower body fat percentage, lower body weight, less stress on the hips and the knees. But number two is strength training specifically is going to strengthen the ligaments and tendons surrounding the joint to take some of the pressure off the joint itself, okay? So exercise is very important in preventing arthritis. Once again, it starts now. It starts in our 20s, it starts in our 30s, if not before then. So how to prevent? Highly, highly encourage exercising on a soft surface. So my runners, like I said, we made tracks for a reason. I know it sucks to run in a circle, but track actually helps with shock absorption, okay? So if we're running on a softer surface, then that puts less load on the hips and the knees, less arthritis, right? And now say you're a runner and you're like, I'm not running on a track. Well, get a nice pair of shoes. And I know my physical therapists are sitting here like, Sarah, why are you telling these people to wear shoes? Like, we are this society where we should actually be barefooted, and it causes a lot of strength issues in our feet and our ankles, right, to be properly supported all the time. Well, yes, but when you're running, get a pair of shoes, has a nice good cushion, lots of shock absorption, just to relieve that pressure off the hips and the knees. Warming up prior to exercise, I know that's one thing we like to skip because we really want to get into our lifts, but the idea is we need to prevent injury, okay? So all the things to prevent injury: warm up, get a walk in, maybe do some dynamic stretching. The next one, which drives me crazy being my exercise background, proper form with exercise, proper form with benching, squatting especially, and deadlifting if you're going heavy, because I will say a majority of the injuries I see in the office are due to improper form while benching or squatting. So, like I said, it's all about injury prevention. Now, next one, never lock out a joint. So I know like my heavy lifters, they go down for that squat, they pop up really hard, they lock out those knees. It's not great, right? That's not great on the ligaments, it's not great on the tendons. Locking on a joint is not what we want to do, right? So, and also, when you lock out, you're actually taking a lot of pressure off of the muscles itself. So if you don't lock out, you're actually making your ligaments and tendons a lot stronger. So, and you'll feel it. You'll notice like, ooh, that's harder when I don't lock out a joint. Next one, cool down, stretch after exercise. That's a pretty easy one. And then one more, which I'll kind of dig in maybe at another presentation, is fish oil. So fish oil is a natural anti-inflammatory. We lack a lot of omega-3s and omega-6s in our diet. So if we can prevent the inflammation occurring in the joint, then arthritis is less likely. Okay. Next one. All right. So say I get a patient. Oh, Sarah, my knees hurt. I cannot exercise. Well, what happens next? They don't exercise. They go months without exercising. Hypertension, high blood pressure. So it's kind of like this cascade, right? So like you stop exercising because you're in pain, and then now you're going into these chronic disease states, okay? So hypertension or high blood pressure is the force of blood against vessel walls. So you go into the doctor, they hook you up to that little thing over your arm. We're checking the pressure in your vessels or your veins and arteries, specifically your arteries. And what is considered high blood pressure? Well, nowadays, our goal is to keep you under 120/80. So a lot of people will be like, oh, I'm right at 120/80. No, that's actually considered pre-hypertension nowadays. And I'll kind of explain to you why here later. So why is high blood pressure bad? So I want you to think of a vessel, right? So if this is what a vessel looks like, and we're stretching that vessel because we're getting more pressure through the vessel walls, we're stretching that vessel, it's causing shear stress. So I also want you to think of a vessel as a muscle, because it is a muscle. It's called smooth muscle. And think about in the gym, when you stress a muscle, what happens? It gets damaged, right? And it hurts and it's sore. The same exact thing happens to your arteries, okay? So you stretch that vessel, you get this shear stress, and your body's like, I need to respond. I need to send inflammatory factors to that area, okay? So inflammation, right? Once again. So that's why it's bad. And once again, we'll get into that in a little bit. The other thing is, if you have chronic hypertension, I'm going to see on your EKG that you have what's called left ventricular hypertrophy. That left ventricle of your heart actually is pumping really hard against this resistance, and it causes the heart walls to get thick. When the heart walls get thick, it can lead to heart failure in the future. So it's just like a regular muscle. If it's overworking, what's going to happen? It's going to fail, right? So you have high blood pressure now in your 30s. When you're 60 and 70, I'm concerned that you may develop heart failure. Okay, so let's kind of dig into the pathophysiology of exercise and hypertension. So remember I told you the vessel itself stretches and contracts. So if you're exercising, what happens with your muscles, right? You get used to that and you don't get as sore. It's the same thing with your vessels. So you don't get as much shear stress when you're consistently exercising. There's less damage to those vessel walls when you're exercising. And this may hit home for some people. That dilation and constriction is actually occurring by nitric oxide. How many people take pre-workout here? Yeah, I know there's more than that. A lot of pre-workouts have nitric oxide in them, right? So nitric oxide is what's responsible for making those veins dilate. The other thing, I'm not saying go, drink a bunch of pre-workout to make your blood pressure go down, because there's other things in that cause your blood pressure to go up. But once again, we're improving that endothelial function with nitric oxide. Next thing, there's a special little protein that's released during exercise specifically called vascular endothelial growth factor. So if you think about that, growing vessels, growing the vasculature, right? So it actually makes our vessels bigger in diameter, but also can make collaterals to blood vessels. So you look at Dr. Bailey, you look at Schlegs, they have all these crazy veins when they're working out. It's because they've chronically exercised this has been released, and they're building a bunch of collaterals off of these vessels to make sure more oxygen is getting to their muscles, right? So when that happens, think about this, the diameter of your artery changes, blood pressure goes down because, well, I have a nice thick diameter, or I have all these new collaterals I can push through, okay? So, and the last thing, insulin sensitivity. There is a pathological link between high blood pressure and hyperinsulinemia, right? That's diabetes. So we'll dig into that when we get to the diabetes section. So I get a lot of questions. Well, Sarah, like, this is only with aerobic exercise. Wrong. Whoa, wrong. And the reason that's a misconception is because strength training really didn't become a big thing until about 30, 40 years ago. If you think about it, everyone was running, everyone was cycling, everyone was doing step up, step box, whatever. Like, no, we need to strength train. And that's new, okay? New in the past 20, 30 years. So I found this study, which was really interesting. We had subjects 3 days a week doing full body movements, right? 65 to 70% of their 1 rep max, and their rep ranges were 3 sets, 10 to 15 reps, okay? So what they found was those diagnosed with high blood pressure revealed decreases in their blood pressure similar to or greater than those who perform aerobic exercise. Now, if you look at this, this is not 1 rep max powerlifting. This is definitely more of an aerobic activity, but the whole point of this is you can still get muscular hypertrophy and the benefits for hypertension with strength training, okay? So you don't necessarily have to go get on the treadmill and run 2 miles to lower your blood pressure is what I'm saying. So that kind of leads me into something really interesting that I think people probably don't know about. I'm going to tell you right now, I am a power lifter at heart. I love powerlifting because I love challenging myself. I know I can go more and heavier, 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 but that may not be the best thing for us. So we have a little cross section of our heart right here, and this is a power lifter's heart. And we have another cross section right here, and this is a aerobic athlete, let's say a ultra marathon runner's heart. Okay, this is a heart cut in half. This is showing me how much your ventricles or your chambers that fill with blood. So in resistance training, specifically powerlifting, what happens if any of you are powerlifters, you know you got that heavy weight on your back and you're looking at yourself in the mirror and you just start getting red, and then you take a big deep breath in, you hold your breath, you go down, you come up, you look at yourself, your veins are popping out, you're super red, right? So what happens there is something called the Valsalva maneuver. You actually are holding your breath with heavy lifting, okay? And when you hold your breath with heavy lifting or you're breathing very minimally, your blood vessels collapse completely. So what happens to that vessel wall, that nice big area, that blood shooting through it, collapses. So that means blood pressure goes way up, and your heart's pumping against resistance, and your heart's a muscle. Guess what? It's going to get thicker. And that's what happened here to this powerlifter. His heart got really, really thick because of all the years of heavy, heavy lifting, okay? So yes, there is benefits to having a thicker heart, but we don't want to chronically do that, right? So if you have a stronger heart, a thicker heart muscle, it's pumping harder. So we like that, right? We like that our heart's pumping harder, but if it pumps hard all the time, once again, it's going to lead to heart failure because your heart's a muscle, right? It's going to fatigue. It's going to fail. Okay, now let's look at the other side of things. Aerobic exercise. This is my ultra marathon runner. So look how big this ventricle is, right? This is the heart chamber. Look how big that is. That's insane. So what happens with aerobic exercise, and a lot of my medical assistants and nurses will say, yeah, this girl, she's a marathon runner, her heart rate's 40. That's really low, right? That's good, though. It's good to have a low heart rate. So in aerobic exercise, you need more blood to your muscle because we need oxygen, right? And with more oxygen, more blood, more volume, our heart ventricle gets thicker, or not thicker, larger, because more blood is going into that ventricle. And so, once again, our more blood in the chamber is able to pump more blood to the periphery, so your heart is not pumping as much. Now, another study I actually read is they measured a specific marker. It's a heart failure marker. Not a heart failure marker, a heart damage marker called troponin in ultramarathon runners after their race, and their troponin levels were high because their heart was working so hard. That's a marker of heart attacks that we measure as providers. So my whole point of telling you this is you need both. You can't just be a power lifter, and you can't just be an ultramarathon runner. Yes, I'm calling out my brother right now. Get in the gym and strength train, but also get off the freaking rack and go get on the treadmill and walk for 20 minutes. I just need you to walk for 20 minutes, that's all, okay? So super interesting stuff here. Okay, moving on next. Okay, so we have this high blood pressure, and we have all this inflammation in our vessels because of that shear stress I was talking about. So when our vessels get big, we get that shear stress. It actually puts a tear in the muscle wall, just like we get small tears in our muscles when we're exercising. So a tear in the vessel wall. And once again, inflammatory factors go to that area, and they're like, what's going on? This vessel is damaged. And what happens next? Well, cholesterol is like, ooh, this is a really good place for me to stick here because it's really inflamed and I like it, right? So cholesterol then sticks to that wall, which then sends more inflammatory factors. Like, what's going on, right? Our body's like, what is going on? So that is what starts atherosclerosis. So atherosclerosis is, once again, cholesterol on the arterial walls. And it leads to coronary artery disease, coronary as in heart disease. And if that vessel gets completely occluded, you're having a heart attack, my friend, right? We don't want that to happen. So how do we monitor as medical providers? I feel like our people here at the Armory do a lot better job at what traditional medicine doctors do. There's a huge misconception. You go to the doctor, you get a lipid panel, and that's going to tell you if you have coronary artery disease. No, it's not. I've had people with LDLs, which is considered bad cholesterol, of 120, and they still have a heart attack, right? Like, it's actually not correlated at all. So what I highly encourage my people to do, apolipoprotein B is more important than an LDL or a cholesterol panel or a lipid panel. And if that comes back high, encourage your doctor to send you for what's called a CT coronary artery scan. This is going to show you how much calcification is built up in those arteries. So especially if you're already predisposed with a high LDL and you have hypertension, you need a CT coronary calcium scan. Once again, just having a high LDL does not mean you have coronary artery disease. You need the high blood pressure and the high LDL in combination for the cholesterol to actually stick to the wall. The other factor, which I don't think anyone in here does this anymore, smoking. So high blood pressure and smoking cause that cholesterol to stick to the wall. So, okay, so think about everything that hypertension did, right, with exercise. Also here, so improving that endothelial function, okay, less damage to the walls. And then, interestingly enough, when we have that inflammation in the vessel walls already because we have high blood pressure, physical activity or exercise reduces platelet activity. And platelets are a major, major thing that are responsive to inflammation. So they're a big immune responder. And if our platelet activity goes down, then guess what? The cholesterol is not going to stick to the wall. The other thing, leukocytes, white blood cells, inflammation, right? Leukocyte platelet conjugates, those combinations, they go down when we exercise. And this is chronic exercise, not short term. This is, you need to exercise 3 times a week, okay? So it's not just one short bout. This is multiple. So, super, super interesting. Now, moving on. Okay, let's dig into type 2 diabetes. So a lot of the times what I see is people are very inactive because they're hurting, because they have arthritis. They get type 2 diabetes, then guess what? They have high cholesterol, and then they have a heart attack because their blood sugars remain so high for so long. Okay, well, type 2 diabetes is actually insulin desensitization, right? So what that means is insulin is a protein, I guess, or a peptide that responds to high levels of blood sugar. And insulin actually works on muscle walls, liver cell walls, so muscle cell walls, liver cell walls, your brain cell walls, to increase that sugar intake, because guess what? Your muscles are working, your liver's working, your brain's working, it needs sugar to operate. So insulin goes and it binds to that cell wall, and there's a special little guy, it's a transporter. It's called the GLUT4 transporter. And insulin says, hey, GLUT4, come up, I need you to get the sugar into the muscle. So the GLUT4 comes to the muscle cell membrane and it says, feed me, I need the sugar, right? But what happens if you have chronically elevated glucose? Well, insulin's like, oh, I'm used to this. Like, I don't need that glucose. And your blood sugar just remains high. Ugh, not good. So then you go down this path of, I need metformin prescribed by my traditional medicine doctor, and then I need a GLP-1 agonist prescribed by my traditional medicine doctor. Then I need all these, eventually I need insulin, right? So what does exercise do? This one, to me, this is literally the cure to diabetes, right here. This is the cure, because guess what? Physical activity does the same thing as insulin. Holy cow. It says that GLUT4, I need you, and it sends the GLUT4 transporter to the muscle wall to bring in sugar. That's the same exact mechanism as insulin, but we're prescribing insulin and we're prescribing metformin and this and that, but we don't say one word about exercise. Holy cow, guys, like, this is the cure to diabetes. You know how many people I've actually had come into the office, they're considered pre-diabetic, and I say, all I want you to do is take a 5-minute walk after breakfast, lunch, and dinner. And they come back and their A1C is 0.2 points lower, and now they're not pre-diabetic. Like, it's that easy. I don't need you to go in the gym and work out for 2 hours. I just need you to do some type of movement, right? And the last thing I always like to point out, once again, it comes down to aerobic versus anaerobic exercise, or aerobic versus strength training. So I told you that these GLUT4 transporters are in muscle walls, right? Muscle cells. So wouldn't it make more sense to, if you have more muscle, you have more muscle cells, you have more GLUT4 transporters, which makes you more insulin sensitive. So if I have my chronic runners or my aerobic athletes, you don't have as much muscle as my strength trainer. And guess what? You stop running, your A1C or your sugar levels are gonna go up. Where my strength trainer, they stop exercising, they have enough muscle, they're more insulin sensitive. So I'm not saying aerobic exercise is bad. I love it. I do both. But I'm saying we really need to strength train, my friends. So that is diabetes for you. Okay, this one I think is going to hit home for everyone because everyone is so scared of Alzheimer's disease because it is a devastating disease, like one of the most devastating diseases out there, right? So what actually happens in Alzheimer's is you get a buildup of a couple proteins. One's called a beta amyloid plaque. The other's called a tau protein. And these are actually cleaned out when we sleep. Right? So I'm not going to get much into sleep today, but this is one thing. If you're a bad sleeper, if you don't get your 8 hours, specifically 7 to 9, you're increasing your risk for Alzheimer's. But also, if you don't exercise, let me just tell you, it increases your risk for Alzheimer's as well. So I was actually looking into someone who specializes in neurogenic diseases. And her name is Sarita Kamani, and she said, "It's a common misconception that we have minimal control over our risk for developing Alzheimer's disease." Oh, well, my mom had Alzheimer's. I don't care if your mom had Alzheimer's, because nearly half of the Alzheimer's cases could have been prevented or delayed by modifiable factors, lifestyle, right? So regular exercises reduces your risk of dementia, which is a precursor to Alzheimer's, by 28%. It decreases your risk of Alzheimer's by 45%. Holy cow. Okay. So these brain changes are actually occurring 20 years before you even have symptoms of Alzheimer's disease. So, why should I exercise? Because when you exercise, the main thing that the brain does is something called neuroplasticity. I gotta find my notes on neuroplasticity. So neuroplasticity is basically your brain is very pliable, and it responds very well to environmental changes, okay? So during exercise, we get this, crazy name. I'm not going to make you guys know this, but it's basically called CREB. And when we exercise, it's released, which transcribes for a special protein called brain-derived neurotrophic factor, that BDNF. And so BDNF leads to what's called neurogenesis. Neurogenesis is formation of new brain cells. So once again, we've been told since we were like 5, you lose brain cells, you lose 1 million brain cells every day. Well, exercise releases BDNF, which actually increases brain cells. The other thing, neuroprotection, right? So I told you about those nasty proteins that build up. Well, what happens, exercise actually helps get those proteins out because you're getting a lot more oxygen to the brain, a lot more blood flow, and guess what gets rid of all that? Your blood, right? So more blood flow to the brain, neuroprotection. And then the last thing is angiogenesis, which is formation of new blood vessels within the brain, okay? So the last thing, that BDNF, that helps all of this, it actually helps increase what's called gray matter in your hippocampus. And if you guys don't know, your hippocampus is your memory center. So if you have more tissue, more gray matter in your memory center, you're less likely to lose your memory in the future. The other thing, think of all the things I just told you about before this. All of those, hypertension, high cholesterol, atherosclerosis, what was the last one? Type 2 diabetes. All of that are precursors to Alzheimer's disease. And what a lot of people don't know, nowadays they're calling Alzheimer's disease type 3 diabetes, right? Well, listen to this. There's a gene called ApoE4. And say you come to me and you say, well, my mom had Alzheimer's disease. Well, you probably have this gene, right? But it has to be turned on, right, for you to actually get Alzheimer's. Well, how's it turned on? It's turned on by blood sugar, right? It responds to blood sugar. So that's why they're calling it type 3 diabetes. If you have sustained blood sugar, you have type 2 diabetes, your risk for Alzheimer's, especially if you have a family history, is tenfold. Okay? So what type of exercise? Once again, aerobic training is what's going to increase that BDNF, all the things I just talked about, right? The formation of new brain cells, the formation of new blood vessels in the brain. But interestingly enough, resistance training increases a hormone called IGF-1, intrinsic growth factor, okay? And a lot of my bodybuilders may know this. They probably inject it. I don't encourage that. But what this does is it's produced in your periphery, specifically after exercise, to promote hypertrophy of a muscle, growth of a muscle. But also, it's a hormone that manages the effects of growth hormone in the body, and it's essential for promoting cognitive abilities. Okay, so it's regulating cerebral blood flow. Once again, promotes neurogenesis, new cell formation, and neuroplasticity. So there's two different mechanisms. We got our aerobic training and our strength training. Both of them combined, once again, are what is going to prevent Alzheimer's disease. Okay? All right, so I'm going to leave you guys with a quick story. And this is my why, right? This is why I get up and exercise every day. So this person here is my dad. My dad turned 70 years old this coming year. He does have 2 grandchildren, as you see in the pictures, which have been a significant motivation for him. So I remember growing up, and my dad was super active, more of like an outdoorsy guy. We would go for hikes, we'd go mushroom hunting, we'd go for bike rides after school. We'd go skiing and snowboarding and whitewater rafting, all these things, so much fun. And he ingrained physical activity into my brain, right? Well, my dad fell into this cascade that I've been talking about, right? He had, growing up, he was an avid athlete, right? He sustained multiple injuries, but he never went to the doctor. That just was not his generation. That was not his parents' generation. And he got really, really bad chronic back pain. They did everything for him. They tried everything. The one thing I told him is, I do not want you to have back surgery. He did it anyway. And now he has bilateral hip arthritis. Well, now he doesn't move at all because he's in pain, right? And I'm sitting here every day after school, or every weekend I'd come home from school from Ohio State, and I'd be like, Dad, listen to this. Listen to what I learned. Listen to what I just told you guys. Listen. Like, listen. Thinking this would be his motivation, right? Not to mention, my dad's parents died, both of them died of massive heart attacks. Massive heart attacks. They just found him dead one day. My grandpa was 64 when he died. My dad was 20 years old and he lost his dad. My grandma, I believe, was in her 80s, but my dad walked into her house one day and she was just laying on the floor. So my dad has really, really bad genetics, right? But in combination of not moving because he's in pain was not good for him. So I get a call from my stepmom about almost 2 years ago today, and your dad is in the hospital. He had a massive heart attack. And I just remember breaking down and crying and looking at my boyfriend and saying, I literally told him for so many years, like, this is what you need to do. That's so easy. Just do this. Just do this. I'm telling you, right? I thought he was going to die. My stepmom, my brothers, we all thought he was going to die. I get down to the hospital. I'm talking to the doctor. You have four, we'll just say 4 main arteries in your heart, right? 3 of those arteries, one was 90% occluded, the other 2 were 100% occluded. So he had maybe 10% of his heart was functioning. They were able to go in, they stented him up, and he lived, right? I remember walking into the hospital and looking at him and saying, Dad, like, if you don't do it for yourself, like, I know you're not scared to die. I know you're a spiritual person. I need you to do this for me. Like, I'm not married yet. I need you to walk me down the aisle. I need you to meet my grandchildren, because I never got to meet my grandparents because of this disease, right? And he got out of the hospital, and about a year later, he got his hip replaced. He's in the mend. He's feeling a lot better. But guess what? His other hip's bad too. So he's still in a lot of pain. My stepmom actually texted me about 2 months ago, and she said, "You'd be so proud of your dad. He walked 2 miles last night." And I'm like, holy cow. Like, this is it, right? So I want you guys to think about your why again, because this is my why. This is my genetics. This is my father, who lost his parents at a young age. And my motivation is the fact that traditional medicine failed him. So every time I sit down with my patients, I see you guys out there. It's because of this, right? This is my passion, right? And my motivation is my grandparents, who didn't have the knowledge that I'm giving you guys right now, right? And my motivation is my future, my children, my husband that I may have one day. Because I don't want to die at 64, right? I want to live a life that's incredible. And guess what? I don't need medications to do it. So think about your why, because this is my why. So this one's for my dad. Questions?
Okay, so you talked about the cascade a lot and how people don't exercise because they're in pain. Mm-hmm. So let's say like you're starting on that cascade. How do you encourage people to get out of that and start living a more physical life, especially if they're in pain?
Yep. So number one, we have an incredible team here, right? I actually see a couple people in the audience who are living with arthritis, and they're training with a physical therapist, a personal trainer. And you start slow. I think there's like this huge misconception that I need to go in the gym and I need to lift 1,000,000 pounds. No, like, I'm gonna do banded work with this person, or I'm not gonna do overhead stuff because she has arthritis in her shoulder, right? So it's starting slow. Typically it's, all right, 10-minute walks 3 times a day. And then I'm going to send you to see Josh and Sarah, our physical therapists, to see if there's anything they can do from a physical therapy standpoint to help the pain. The other thing is recovery, right? So we have all these recovery modalities, the cold tub, the hot tub especially for arthritis. It helps loosen up the muscles and the joints. So a lot of the times, it's a combination. It's 100% all of us together that are going to make this person's quality of life better. So. Man, I must have done a really good job explaining it. Because that stuff is complicated. Like, it's complicated. Ken?
I loved your comment concerning concerning Alzheimer's, because it is genetic in my family. And since I've been in my 40s, I've been petrified.
Yeah.
I'm now in my 80s. I may not sound like I'm making sense, but I'm doing a lot better.
You are.
But I agree so much with you, having trained with you initially, and Sean, in getting here and doing it 3 times a week. I'm still at 2. Eventually I'll get to 3. But it has made an enormous difference. And I went to, in D.C., a number of, Georgetown put on a number of examinations of their research on Alzheimer's. And I think what I walked away from that was that it's basically what you eat and how you exercise.
You got it.
It's the same treatment as for heart disease.
Exactly. Yep.
So I just wanted to,
Yeah.
and
awesome.
thanks so much.
Yeah, absolutely. I think
Sarah, good morning. Good to see you again.
You too.
So one thing I was curious to know a little bit about. So the diabetes portion.
Yeah.
It was mentioned like traditional medicine has failed us. So what do you tell the patient, like the diabetic patient, who, like you said, their A1C may be really high? ADA guidelines say, hey, you start getting on medications, cholesterol, hypertension. What do you tell that patient then when they have to be on those medications according to those guidelines, specifically when exercise may not be enough for those patients?
And you kind of hit the nail on the head. When someone is living with that disease chronically, like they were diagnosed when they were 40 and now they're 70, like there is not a lot we can do. But once again, insulin does the same exact thing as exercise. So what I tell those patients is, I'm going to monitor the heck out of you because I don't want you to be on these medications forever, right? There's nasty side effects associated with a lot of things. There are some diabetes medications that are very benign that I'm okay with them being on. But I usually say, once again, I want you to start with walks. Just a walk, 5-10 minutes after breakfast, lunch, and dinner. And then in 3 months, you're going to come back. We're going to check your A1C. We're going to check your lipid panel, your ApoB. And then we'll see what happens. Because guess what? I guarantee you I can take you off of one of those meds, right? So what's different between what we do here in traditional medicine is I can see that patient a lot more often, right? As long as they're okay with it, I can draw their blood every week if I want to, right? But 3 months tends to be the best. So I have them come back in. We start by setting tiny, tiny goals. I maybe set them up with Sam, our dietitian, to see what we can do from there. And then I just say, once again, exercise, walks 3 times a day, 10 minutes, follow up in 3 months. We'll reassess those goals then. So.
Awesome. Thank you.
Sorry, this is a bit of a drawn-out question, but say when you were younger, you dealt with a lot of uncontrolled depression and anxiety, and then as you've gotten older, you've learned how to take care of yourself in a healthy way. You're not on any medications or anything, but you're experiencing loss of memory. Are those same proteins that you mentioned about Alzheimer's, are those same proteins being built up in your brain, or do the two even correlate?
They actually do not correlate. Typically, depression and anxiety are more neurotransmitters like dopamine and serotonin, whereas the proteins that build up with Alzheimer's, they're not supposed to be there, right? So depression and anxiety are more, you're lacking certain neurotransmitters, whereas with Alzheimer's, you're building up these nasty proteins that shouldn't be there. Does that make sense? Yeah.
Thank
Mm-hmm.
Hey, okay, so
question for you. So your why very similar to mine is my dad.
Yes.
However, my dad is partially paralyzed.
Okay.
And so one of the biggest things that I've struggled with is getting him to find ways to exercise that he's able to with physical limitation.
Yep.
So what modifications? So he's partially paralyzed from the waist down on
Waist
his
down.
right side.
Yeah.
So balance,
Yep.
treadmills, bikes, all of those things non-existent.
Right.
So what would you recommend as kind of best ways to add physical activity
Yeah.
back into the life so he can strength train and do aerobic to still fight it? Because now he's on the verge of like getting diabetes and like
Yeah.
all those things.
Yeah. So I think, in my opinion, we actually do have a patient of ours that's training with Kaylin, who's also he's what is he? T2 down. So he's still able to use his arms, and she's done a really good job. And now Anthony and you and Dean in combination have done a great job with him. I highly encourage these people not to use the remote wheelchairs because this is still activity, right? It's just like walking for us. So I highly encourage an actual wheelchair to start. And it's once again the same like concept as someone who is able to use their lower body, right? 10 minutes, we're gonna go on a walk, right? This is their walk, and we're gonna do it 3 times a day. And then we're gonna put them through an upper body strength training session, right? So it doesn't have to be crazy. You're still getting exercise with that movement. So
What about for patients who have balance issues, right? So like he still walks and does all of those, and so we've done some of those limitations.
Yep.
But for balance purposes, he can't do a lot of weight bearing because it throws off his balance because he has no feeling. So how would you recommend going about that work?
yeah, so I do, like with my balance people, and I know I got some people in here that I deal with, I do a lot of like sit to stand and making sure they have a wall to hold on to. And if I'm doing sit to stand, I kind of go, oh, we start like at this height and then we go down as they get better, right? So I always start both legs, and then if they get really good, maybe we do a single leg, but always making sure there's something that they can catch themselves with. I guess that's where I would start with from a balance perspective. I also really, really like farmers carries, like suitcase carries, that kind of stuff, which may be a little advanced. But like I said, the chair and making sure there's a wall, yeah. Anyone else? Ken?
On the balance, I have what's called a balance
Board, yeah.
and it is wonderful.
Yes.
It's very hard to do when you start off,
Yep,
but if you get where there's a wall to assist you,
exactly.
and then you get on it and try to maintain that balance for like 30 seconds and then a minute, and then you can get to 2 minutes, and it is wonderful. So,
Exactly. Highly, highly encourage balance boards, especially for my elderly population. All right, anything else? Okay, thank you for having me.
Thanks, Sarah.
Yeah. Was it really good?
I've called you all here today.